Welcome to The Hill's Coronavirus Report. I'm Steve Clemons, editor-at-large of The Hill. Each day we are interviewing consequential voices in the global battle against COVID-19, which is the defining challenge for the United States and much of the world in this era. There are heroes and there are villains in this time of stress, and today we are fortunate to have with us one of the great heroes, Dr. Leana Wen. She's the former Baltimore City Health Commissioner and current professor of health policy and management at George Washington's University School of Public Health. She is one of our nation's leading public health infrastructure voices and has been just about everywhere trying to help people understand that they have agency in the course this virus takes. And she did this all while just about to have a wonderful baby girl, Isabel, which she did this past weekend. Leana, thank you so much for joining us and congratulations. First of all, how is Isabel and how are you?
Thank you for asking, Steve, and thank you for your terrific work and leadership on this and so much. My family's doing well. I feel very fortunate to be home now. We're going to be staying at home for the time being with Isabel and her 2.5-year-old brother and my husband. And I think it's just I've so much appreciation for the healthcare providers who are doing tremendous work. And it's not only the frontline workers in the ER, in the ICUs, it's all the healthcare professionals who are showing up to work, who are potentially exposing themselves every day to people who are asymptomatic carriers, and who show up every day to do incredible, dedicated work.
Right. Oh, I know that you have a dashboard, when you look at these things, having been a commissioner for health of a major city in the United States, I imagine you know what it's like to be looking at New York or some of the other major metropolitan areas that are just under huge duress. What does that dashboard look like to someone in that role right now?
There are a number of factors that people would be looking at. Certainly the immediate factors that are being reported every day. You have the number of deaths as the most stark, and the one that stands out the most. But that is the number that actually lags several weeks behind the other numbers. You have the number of hospitalizations and then the number of new cases. And then we also have to think about the fact that all of these numbers right now could be inaccurate and probably are all inaccurate and are underestimates of what's actually happening.
Is that because we're not testing people out there? I mean, we have been hearing stories of so many people dying who are not in hospitals that are not part of this count. We heard in Korea, for instance, that there may be a ratio of 1 to 10. They did a ton of testing, but the Koreans think that 10 times more people had the COVID-19 virus than were tested. Is that what you're looking at?
That's exactly right. We don't know what that ratio is here in the US. I've heard the CDC put out estimates somewhere between 25 and 50%, as in perhaps 50% of people who have COVID-19 in this country don't know that they have it. And then we also know that people who have symptoms of COVID-19 are not able to get tested still. They're told to go home and self-isolate and assume that they have coronavirus, which is the right treatment. But that's not helpful for diagnostic purposes. It's not reassuring to the patient and their family members. And it's not helpful from a public health perspective because that number of diagnoses is almost certainly a significant undercount of the actual number of cases. And so what I fear, and to your original question, Steve, what I fear is that there are communities out there that think they are fine, but actually there are outbreaks that are happening right under their noses and they just don't have the surveillance tools to find out. And by the time they see the number of cases rise, it's going to be too late.
Right. Leana, you and I talked before this became a crisis in the United States when it was still mostly in China, that it had popped up in a couple of other places. There was a ship off of Yokohama Harbor in Japan. It was not felt in the U.S. yet. And you warned that this could happen, that we had to invest in public health communications and take strategies that would help mitigate the possible spread of this. How have we done, given that conversation we had now a couple of months ago?
Frankly, very poorly. It's easy to look back and be the armchair quarterback and say, well, we should have done these things differently. And I think there's a lot that would be hard to predict because of just how quickly things were moving. And I think our public health officials federally and in the state and local levels have done a tremendous job with the limited resources that they have. But there are two major failings. One is the failure in the first place to invest in public health, recognizing that public health, as you and I have talked about, Steve, that public health often works when it's invisible. And so it is challenging to put in that investment in the first place into something that doesn't look like there's a face to it. But I think the second thing, and this part is the one that I think is the least forgivable, which is that even after we realized how big of a crisis this is, and even after there were calls and continue to be calls by local officials about the desperate need for things like personal protective equipment, PPE, and ventilators and tests, even after these desperate calls were made so public that the federal government still has not acted with the urgency that's required. And I think that is the part that I think we get a failing grade on and continue to get a failing grade on.
Has the administration done anything right in your view in the early days of this or since? Where are you heartened, and where else are you really disappointed?
I think there were initially some good calls and just calls that were difficult. Look, I wrote an op-ed for the Washington Post back in early February saying that it's okay that there is course correction. Just because things are evolving, we actually would expect that there is constant reevaluation and changes in strategy. So what happened, for example, with the initial lag in testing was a big problem. But what's necessary is to recognize that it was a problem and then anticipate for what happens next and then really ramp up once you know that this is a barrier. So the fact that it happened in the first place, yes, there was a misstep. Missteps happen, but then it's what you do after that to course correct that's the issue. And I think that's what I'm troubled by, that there is a failure to since say, okay, some things happened that were not ideal, but now we're going to fix it. And this is the plan. And instead, we keep on hearing things like, oh, well, we hope that we're going to get to this soon. But hope is not a strategy, and soon is not a timeline. And people on the front lines who are facing illness themselves, who are fighting disease every day, they cannot bank on no timeline, no quantity, and no strategy.
You know, when we met years ago, you and I, you were running the Health Commission in Baltimore, and I was disturbed that in different parts of Baltimore, you had people that had 20-year difference in life expectancy. That's way before the COVID crisis hit, and we're now seeing data that are showing that African Americans are dying at far greater rates than any other group, and greatly disproportionate to their population. We're seeing this with Hispanics as well. But in urban centers, it's really Black Americans. And I'm interested in whether you think this new epidemic that is hitting us is going to make all the problems you were trying to deal with in Baltimore back then much, much worse.
You know, there was a map of Baltimore that I often showed when I was the health commissioner. And then I actually stopped showing the map. And here's why. The map was the map of our city by life expectancy. You could see certain neighborhoods, as you mentioned, Steve, where there was a 20-year difference in life expectancy. While those same neighborhoods that had the lowest life expectancy also had the highest drug overdose rates, highest mortality from cardiovascular disease, highest mortality from HIV, lowest socioeconomic and lowest level of education attainment, highest level of incarceration. I mean, whatever you consider to be the social determinants of health were reflected in that map. And it's not surprising that with COVID-19, we see that same pattern of disparities, because frankly, these are the systemic inequities that have gotten us to where we are today. That's reflected in every single health crisis and every single crisis in general. And COVID-19 is unmasking many of these deep inequities and frankly, systemic racism that have long plagued our country.
So when you talk about, you combine that, you hear this data, we were just talking about personal protective equipment and gear that's in short supply, and governors are on edge around the nation, and we know that this is moving like a wave. I mean, one of the interesting things that hasn't gotten a lot of attention yet is what's going to happen in rural America. Right now we're seeing it in urban America, whether or not we have this. And I guess I want to, as we think about this, is there anything to be optimistic about? I mean, as you look at this, we've got lots of warnings. We have people like you trying to guide us through on what we should be doing. Is there any glimmer of, I won't call it hope, but of light in the process?
I believe so, yes. So, a couple of things. One is the experience in other countries. We look at, you mentioned South Korea earlier, and South Korea and Singapore, Hong Kong. There are other countries that have been successful in containing COVID-19 through aggressive public health measures, widespread testing, and critically in strengthening their healthcare system. We also see glimmers of hope right here in the US with California and Washington state. Very early on, they were the first states that were experiencing outbreaks and community transmission because of their early, aggressive, and consistent actions in implementing social distancing measures. They have been able to flatten that curve. They have been able to reduce the rate of transmission and give their healthcare system a chance to catch up and really support these critical cases. So we know that it's possible to do in other countries and here in the US. Now we just have to get the resolve to do it here too. And we have to continue with aggressive social distancing consistently across the country, while, and I stress this too, that the federal government absolutely must step in with a national coordinated effort to strengthen our healthcare system, get these supplies to people, to areas that need it the most, and really recognize the seriousness and urgency of the crisis that we're facing.
What should we be doing for people on the front line, the healthcare workers that you're talking about that are part of the public health infrastructure? I mean, is it a death sentence for them, or at least a significant number of them right now? Governor Cuomo in New York has, to some degree been celebrating the fact that more than 6,000 retired folks have come back into the mix of this. But we hear these horror stories of large degree of those healthcare workers becoming infected with the coronavirus.
I mean, healthcare workers, nurses, doctors, respiratory therapists, all those on the front lines, we go into our profession expecting to be sent in to battle. We expect to be fighting for our patients. We expect to go and work under these extremely challenging conditions because that's our job, that's our obligation. But we do not expect to go in without the protection that we need to do our jobs. And I think that's been what's the most troubling. I mean, there were reports 2, 3 months ago about what was happening in China with doctors who were going in with raincoats because they couldn't afford, because the hospital ran out of gowns, or nurses who were spraying down their masks and making them really wet and ineffective, but that's the best they could do because they were out of masks. And no way did we think that this could happen in the US. But that's what's happening every single day now. I mean, I was just in the hospital for birth, and I saw that in my hospital, which has yet to experience a peak in outbreaks, they are rationing masks to the point that every provider is issued one mask a week, and that's what is happening now. And so, to your question, Steve, I mean, I think healthcare providers are willing to do everything they can, but we should not be sacrificing their lives in order for them to do their job. And frankly, we as a society have an obligation. We need to be getting them personal protective equipment. So we ourselves should not be hoarding masks and other supplies, but we should also be pressing the federal government to do their part. It's nice that we are doing all these celebrations for our everyday heroes, but we need a lot more than words. We need actions to be.
Well, I will leave it there. Thank you so much, Dr. Leana Wen. Thank you for joining us today. Again, congratulations on your newborn daughter, and thanks for sharing so much of your perspective during this complicated time. And thank you for joining me for the Hill's Coronavirus Report.